2021, the last RLR of the season, the last VMR of the season. I'm so glad that we've all made it to this day. And we wish each and every one of you a healthy, safe, and amazing New Year's. And hopefully 2022 is going to be an epic year full of health and joy for you and your loved ones. Now that we're done with this public announcement, I'm going to pass the mic to Robbie to see how he's doing.
Hello, good morning, folks. I'm doing very well. I'm wearing a Christmas hoodie on New Year's Eve, which tells you everything about my life. It's a little bit just, I always get close somehow, but I'm off in some way, shape, or form. And I'm super excited today because, well, one, for all the reasons that Prof. Rez mentioned, but also the crazy part about it is it wasn't a hard call, honestly, to hang out for an hour with you all to cap off the new year. I think VMR has meant a lot of different things to a lot of people. And I don't think we could honor it in a better way than to hang out for an hour together and to nerd out about medicine, to celebrate, I think, probably over 300 VMR. I mean, I know there's 365 days in a year, and there's no way we miss 65 days of VMR. I think the CP solvers wouldn't have it any other way. So thanks for hanging out for at least 300 days this year. And we're excited that we have a case presenter who actually reached out to Rafa to present a case today. And I want to make sure I get your name right. Is it Carolyn or Caroline, or how do you pronounce your name?
Yep, Carolyn.
Carolyn, awesome.
Yeah.
Well, welcome. You want to introduce
Thanks.
yourself to us?
Yeah, so hi everyone, my name's Carolyn. I'm an MD PhD student at the University of Kansas. So I defended my PhD this spring and now currently back as a third-year medical student doing my clinical rotations. So I tried to tune in for VMR whenever I could when I was working in the lab during my PhD, and I found that was really helpful for kind of making that transition back to the clinical world after that 3-year hiatus. So I'm excited to get a chance to contribute finally.
Amazing. I think Maria says it well. Congrats, Dr. Kaufman. That is awesome. I also just love the terminology we use in science where we say, like, you have to defend your argument from attack from the outside. It's just so telling of how we do things in medicine. But congratulations on a successful defense and earning your PhD. All right, why don't we rock and roll? I'll have you jump on in and present the case.
All right. So this is a 53-year-old woman who presents to the emergency department with weakness. So do you want me to go on the HPI a little bit? Okay.
I'll just share real quick that my first thoughts immediately are going to be paying attention to two things. Is she predominantly weak at rest? And is it symmetric? If those two, if she describes that her whole body is weak, and she feels that weakness just sitting there, we're going to move pretty quickly away from neurological causes of weakness. But if there's any symmetry in Carolyn's next words, or any sense that she's actually fine when she's sitting there, but it only occurs when she lifts her leg or moves her arm, we're going to go into neuro world. So pay close attention to many things, but those two questions: is it symmetric, and is it prominent at rest? And that'll rapidly split our differential.
All right, so she reports progressive numbness, tingling, and weakness in both hands for the past 3 months. She says her fingers feel tight and like they're frozen, and she can no longer knit. And over the last 3 weeks, she's had weakness in her arms and legs that's progressed to the point that she can no longer walk upstairs or lift her arms above her head. Recently, she's also had swelling of her legs and feet that seems worse at the end of the day. And she describes occasional shooting sensations in her hands, but otherwise reports no pain. She's not had fever, rigors, shortness of breath, cough, nausea, vomiting, diarrhea, unintentional weight loss, skin changes, or any recent falls or trauma.
All right. Well, it seems like we got another neuro VMR, and I don't know if Maria's not doing the teaching for it. If she were, she actually adds more teaching than we actually make during the episode. But Robbie, why don't I focus on just laying down the framework for the neurologic problem, and then you add whatever you have to add to it. So I think right away, we have to sort of step back and use Aaron Berkowitz neurology equation, which at its element is localization times time course. And the time course you can think of as hyperacute or sudden, acute, subacute, and chronic. And what we mean by hyperacute, we're literally talking seconds to minutes. So think a migraine, a stroke, a subarachnoid hemorrhage, some kind of traumatic event. Acute puts you in the landscape of inflammatory processes, specifically typical bacterial infection and demyelinating diseases like multiple sclerosis. Subacute is more atypical infections and paraneoplastic or neoplastic phenomena. And the chronic is more degenerative processes. There are two categories that can happen, hyperacute and chronic, and those are your toxic metabolic. So that's just a brief overview of how we use time course to prioritize the neurologic DDX. Right here, if we were to put a time course on this patient's neurologic problem, it would be in the subacute category. Remember, anything that's acute can potentially become subacute if it's not diagnosed. So just because we're in the subacute category, it does not rule out inflammatory demyelinating processes. Now, if we step back and say, what is the neurologic syndrome that we're working with? And how do we localize a neurologic problem? You have to start at the most basic before zooming in. What do I mean most basic? The most basic, is it an upper motor neuron process or a lower motor neuron process? And note, Robbie kicked us off by talking about weakness. Is it true weakness? Is it not? Are we going to go down the neuro route? Here, as soon as Carolyn mentioned these tingling sensation, these sharp sensation, we know there is some kind of neuropathology. So if we think about the CNS, and maybe what I'll do is I'll focus on the upper motor neuron and then pass it to Robbie to see if he can explain these findings with a lower motor neuron process. So in the upper motor neuron process, you have the brain, the cerebellum, the brainstem, and the spinal cord. So if we look at this patient's presentation, and we haven't even got to the physical exam because of course spasticity, reflexes, all of this will be crucial in pinpointing the neurologic site of pathology. It would be awfully odd for this to be a problem in the brain. Why do I say that? Because we're having some symmetry here. And so you would have to have like multiple sites of pathology, which may happen with embolic phenomenon, but they don't typically present like this, given there's no systemic signature whatsoever. So I'm just not too excited about the brain being the site of pathology. The spinal cord, however, that's definitely a possibility. And I'm going to be really keen on the past medical history. Does the patient have a history of RA that makes us concerned for any kind of cervical pathology, for instance? On the physical exam, I'll look at the reflexes. But could there be something going on in the cervical spinal cord? Remember, information has to go from the top of the brain down to your extremities. So if you have a problem at the cervical spinal cord, before you get to the nerves that sort of stimulate the muscles of the legs to contract, if you interrupt that pathway, you may have weakness in the legs too. So right now, Robbie, when I look from just an upper motor neuron perspective, and I'll give you the mic for the peripheral nerve and the edema and the other factors of this case, like if I were to put the lesion in the upper motor neuron, it would be at the cervical spinal cord, somewhere there where the nerves are being irritated, giving you this sensory motor impairment, though this does not say what's causing the pathology of the nerve. It just says that's where I would put the lesion if we were dealing with a spinal cord process.
I absolutely love it. I think that's superb. And in terms of the peripheral nervous system, myopathy is triggered by the words, I can't lift my legs up or lift my arm above my head, but then weakened by the presence of sensory symptoms. Sensory symptoms shouldn't be there in the presence of a pure motor syndrome, but here's the caveat. I've seen cases where somebody has such aggressive neurologic disease in their muscle that they get muscle edema and then peripheral nerve compression. So how can you get a myopathy with a neuropathy? The muscle gets so big, it compresses the nerve. Any neuromuscular junction disorder would have to be presynaptic to involve sensory issues. So when you divide the neuromuscular junction, you should divide it as the part that's close to the muscle and the part that's close to the nerve. And myasthenia is a postsynaptic, i.e. muscle-based NMJ disorder, and Lambert-Eaton is a presynaptic. And so here, both the muscle and the postsynaptic are a little bit less likely in the face of sensory symptoms, leaving the peripheral nerve, the presynaptic neuromuscular junction, plexus, and then the nerve roots as they exit the spinal cord. Because Reza divided the RRs divided the CNS and the PNS, but remember that the central nervous system and peripheral nervous system exist like this. And so sometimes you get lesions at the juncture of these places that cause kind of tricky neurological disorders, like chronic meningitis, where you actually have irritation of the actual cord or brainstem, but also irritation of the nerves as they exit. So diseases at the CNS-PNS junction, like cauda equina, and anterior horn diseases can be a little tricky. So lesions at the anterior horn cell in the nerves as they exit the spinal cord, the nerve itself, and the postsynaptic junction are totally fair game. The edema is very intriguing, and it's intriguing for a simple general principle in that most neurological diseases do not involve the systemic circulation. Meaning when somebody has a stroke or somebody has a neurological process, it tends to be a neurologist only on the case with very little role for a rheumatologist or an internal medicine doctor. And so here the question is, do we have to deviate from the base rate? And the base rate would say, hey, this edema means nothing. It's probably a little bit of venous stasis in somebody who's not moving. Or is it part of a systemic issue involving the neuraxis? And that's when we go back to our trusted trifecta of cardiac, nephrogenic, and hepatic causes of edema. And the overlap between edema and neuropathy, there are some diagnoses that are super esoteric to entertain, but if I were to say them out loud now, it would mean that I would be thinking them in real life, which would be not true. So I will not say them out loud. But I'm being honest in that the nerdy part of me is thinking about them, and we'll see if they come up later. All righty, back to you, Carolyn.
All right, so past medical history, she had migraines and asthma as a young adult, but otherwise has not seen a physician in over 10 years. No medications. Her father has Parkinson's disease and COPD, and mom has diabetes. No history of tobacco, alcohol, or drug use, and she's monogamous with her wife. She owns and runs a local home goods store that requires frequent international travel to Europe and South America. No allergies. Her vitals, she's afebrile, heart rate 104, blood pressure 132/84, respiratory rate 16, and satting 98% on room air. So she was non-toxic but anxious appearing, normal weight, normal conjunctiva, extraocular movements intact. She was tachycardic but had regular rhythm, no murmurs, rubs, or gallops. She had faint bibasilar rales but no wheezing or rhonchi. Abdomen was soft, non-tender, non-distended, normal bowel sounds. She was alert and oriented ×4, cranial nerves intact. Her shoulder abduction and hip flexion were 3 out of 5 bilaterally, and elbow and knee extension were 4 out of 5 bilaterally. She had significantly decreased hand grip strength bilaterally. Her reflexes were 3+ throughout, including a jaw jerk. She had significantly diminished vibratory sensation in both hands and slightly decreased sensation in both feet. She was able to stand and walk only with assistance, but had no ataxia. I noted some mild nail clubbing. When I asked her about it, she said, yeah, actually that's been maybe a couple weeks. I noticed that too. She had trace bilateral lower extremity edema, but 2+ radial and dorsalis pedis pulses bilaterally, no rashes or cyanosis.
Carolyn, you clearly have been to VMR quite a bit. This is just such a seamless presentation of a I mean, you're picking up clubbing and travels to Europe and South America. This is like a very well put together case, and really appreciate you presenting it here today. I'll just tackle the background data and leave the very intriguing exam for Prof. Rez to ponder. These are rapid associations that you should not be doing in real life, and they only occur now in the context of practice, because the real life scenario would be you'd analyze the exam, take it as far as you can, then go back and see how does the history help you. But some rapid sort of like S1 thinking that you might consider uploading is whenever you hear the word asthma and any neurological syndrome, you should think about EGPA or eosinophilic granulomatosis with polyangiitis, just to make a rapid association. Parkinson's disease, most of it is acquired, though a fraction of it is hereditary, and so that might cross your mind. Anyone with a family history of diabetes is also at risk for diabetes, and there's a long list of diabetic complications that involve the neuraxis, which we've reviewed, I think many of them in VMR. Travel to Europe and South America often evokes the possibility of infections, and it's just interesting to reflect that infections don't really overlap with neurology much, especially the peripheral nervous system. The only infection that I can think of is leprosy that can cause neurological consequences directly. There are all sorts of ways that you might connect infection and neuro, though, with HIV and Hep C and pyogenic infections causing compression like an epidural abscess. But those are much less common. In fact, much less common as a direct connection. And the patient doesn't seem to be at high risk for sexually transmitted infections, but whenever the neurological syndrome is compatible with it, you should consider testing for HIV, syphilis, and many of those, regardless of the baseline sexual risk factors. So honestly, not much to work with in the background history, especially since we don't know where this lesion is yet. So I'll pass the mic to Prof. Rez to analyze the exam.
Wow, what a amazing setup and tricky exam, and would love to hear your thoughts, Robbie, after I analyze it, see what additional thoughts you have. But I think right away, when I look at this exam, of course, like we want to focus on the neurologic assessment, but prior to that, you have to look to see if there's any evidence of a systemic disease entity, because many times, like Robbie mentioned, the processes that affect primarily the CNS don't leave their mark outside of the CNS in terms of inflammation. Many times, not always. So right here, when we look at the vitals, you see that this patient is tachycardic. So there's something that is, bothering this patient. Now, tachycardia has a broad DDX, but that's already a red flag, making me not rule out the possibility of an inflammatory process. Of course, we'll look at the patient's labs and see if there's any other data point to support inflammation or not, because that's going to be a crucial branch point here. Then when I heard the lung exam, my mind was like, okay, some rouse, maybe atelectasis, let's move on. But then I paused once I heard the word clubbing, because if this was just atelectasis, I would not expect there to be clubbing. What does clubbing signify? And I'm going to teach you via this VMR how to assess for clubbing that is much better than the doctor who identified clubbing. Who was the doctor? That was Dr. Shamrock. And what Dr. Shamrock had was endocarditis. And he was documenting all of his nail changes. And he was the one that first showed clubbing. And how weird is it when you tell your patient to do this? Like, I can barely do this. And then you're like, hey, can you see through that window? That's not the way to assess for clubbing. The way to assess for clubbing is look at your DIP joint and see how this section right here where I'm holding my fingers is taller than this section right over the nail bed. You see how it goes down like this? If it doesn't, please send Robbie an email and he'll further evaluate that. But it should taper down. That's so much easier. And by the way, you can look at the nails on the feet. You can look at a bunch of fingernails. So bravo to Carolyn for detecting the clubbing, because it puts a whole new flavor on this rouse. So now I'm not convinced that this rouse is just atelectasis. So are we dealing with a neuropulmonary syndrome? we haven't got to the labs to see if the liver or the kidney is involved. So now I have two overlapping Venn diagrams of some kind of neurologic problem and some kind of pulmonary problem. And with pulmonary problem in RALS, it ultimately comes down to something is filling the alveoli if the alveoli is not collapsed. And I don't think this alveoli is collapsed. So we had to think, what can be filling it? Well, it can be cells, right? You can have white blood cells, red blood cells, you can have H2O, you can have protein, you can have cancer cells. It's a long DDX. Here is where I use the time course. We know that this patient has no reason for heart failure. There's no jugular venous distension. There is some lower extremity edema, but no other factors really like made me reflexively think of heart failure. So I wondered, could we be dealing with some atypical infection in the lungs that now is involving the nervous system? I think we can dive even further there in the DDX. And maybe, Robbie, I can just pass you the mic and see like where else your mind takes you before we assess the neurologic exam.
Yeah, I was just pulling up a schema for clubbing, and I think you're right. Like there could be a heart issue like endocarditis or a lung issue, and the lung issue can be an infectious issue or a malignant issue. And then there's less common causes like cirrhosis and Graves' disease and whatnot. But I don't have anything to add. I think you ended with such a great summary. The key question is, what is the process in the lung and how that can affect the nervous system? So yeah, I'm right there.
And I think that this hyperreflexia like has to prioritize like something in the spinal cord, which is what we were concerned for, as much as like we're still worried about the muscle itself, but I think the tingling and now the hyperreflexia should at least point us towards the spinal cord. We may have additional muscle pathology. So I think this patient warrants an MRI with gadolinium of the entire spinal cord to see if there's pathology there. I'm worried about myelopathy, basically.
100%. I actually have a question. I was going to look it up and I was like, man, why would I look it up when I have 30 people on VMR? I agree with you. My mind immediately went to the spinal cord. Then, honestly, here's the real craziness. I was doing this and scratching my jaw. I'm like, wait, my jaw is way above my spinal cord. So does a jaw jerk? I don't know where a jaw jerk localizes. Does it localize above? Like, does this tell us it's brainstem? Which we can easily look it up. But if somebody knows, type your answer in the chat and let us know. But I agree with you. Like Maria's pulling out Aaron's book. This is great. Let's just hear it directly from Aaron. Because I think when Aaron teaches us, he's like cranial nerve equals brainstem. So I don't know if this is a cranial nerve reflex. Do you know, Prof. Rez?
I don't, to be honest, what my mind did was like, man, I don't know too much about the jaw reflex. Let me just jump over it and focus on what I do know. But now that you raise it, like, honestly, I think a MRI of the brain is also an indicator.
Amazing. It looks like, Gail, do you want to unmute and tell us more? If you can. If you can't, no worries at all.
Sure. I looked it up because I was like, I've never done a jaw jerk reflex in my life, but it looks like there's a kind of a stretch reflex, kind of, with your ankle reflex with your knee, but with specifically the trigeminal nerve with a pathway in the masseter muscle. So if you put your finger under, the way that they do the reflex, they put the finger underneath at the chin area, and then they kind of you ask the patient to open their mouth just a little bit and you tap it, and you really shouldn't see much movement at all. Sometimes it closes a little bit, and if it's a positive reflex, it's their mouth will open. So it's essentially like clonus, except instead of in the ankle, it's in the chin, in the face. So it is localized to the upper motor neuron, cranial nerve 5, specifically the trigeminal nerve.
Amazing. Gail, where are you calling from?
I am calling from Columbus. I'm internal medicine resident at Ohio State.
Oh, amazing. Thank you for joining us and for teaching us about neurology as an internal medicine resident. That's so cool. So yeah, Prof, I'm right there with you. Like, what is it? A spinal cord, brainstem, and what's the lung stuff? All right, Karen, mic's yours.
All right, so white count is 9.8 with normal differential. Hemoglobin 13.4, platelets were 321. Sodium 138, potassium 3.9, chloride 103, Yeah, sorry, the white count was 9.8. Yeah. CO2 26, BUN 21, creatinine 0.61, glucose 78, calcium 8.6, mag was 1.8. Yeah, and then AST was 261, ALT 336, alk phos is 60, total bili was 0.5, and albumin was 2.6. A1C, like hemoglobin A1C was 5.2, TSH 3, B12 was 420. Her UA showed 2+ protein, 3+ blood, negative nitrites, 2 to 10 white blood cells, and 0 red blood cells. Sorry, 2 to 10 white blood cells and no red blood cells, yeah.
All right. Well, thank you, Carolyn. I still have zero idea what's going on here, but I'm really excited to be involved in this case discussion. Maybe what I'll do is I will tackle the liver chemistry test and then pass the mic to Robbie. I think that the CBC is helpful to some extent in that we don't have any severe derangements, though I was expecting a little bit more in terms of like anemia or maybe thrombocytosis, but we don't have that. And that's fine. You don't need everything to support inflammation or not. When we get to the liver chemistry test, we notice that the AST and ALT are elevated. Now, this prioritizes something happening in the liver. We do know that AST is ubiquitous, meaning it's present in many cells. So it can be elevated for different reasons like rhabdo, hemolysis. But here our attention goes straight to the liver. And what we would sort of frame this as is hepatocellular liver injury. And the ALT is even more specific to the liver, and it's easy to remember that with the L, but you have to also be cautious here because the ALT has a longer half-life than the AST. So you can have extrahepatic causes of AST and ALT elevation that have this pattern just because the insult happens. When the insult wanes, it just takes longer for that ALT to sort of degrade. So this is just giving us one snapshot. I would love to know what the trends are for sure. But if we do frame this as a hepatocellular liver injury, then we know we have neurologic problem and we know we have pulmonary problem. The top causes include viruses, toxins, and then you can go into more esoteric causes, but those primarily like autoimmune hepatitis, PBC, they primarily leave their signature within the liver rather than the nervous system. So where I am right now is I'm wondering, is the liver involved? If I wanted to say it was some kind of infiltrative process, it's odd that the alk phos is not elevated. So I don't know if this is truly representing liver injury as opposed to injury elsewhere. And now we're seeing the delayed breakdown of that long half-life of ALT. But that's just focusing on the AST and ALT. Would love to hear Robbie's thoughts with incorporating the UA.
You know what, folks, you see how he set me up there because he kind of knows what the UA does. And I appreciate it. I'm going to talk about that in a second, but I'm trying to be more transparent about, I think, how people reason clinically. And I think what Reza and I do and what people do when they're seeing patients is they like try to come to an answer and then you look at something, you think of it, and then you try to like show your work. And so I just want to be honest that every time I try to come to an answer, I hit a roadblock. Like every time I try to synthesize this case and I go back to it, I hit a roadblock. And so I think it's even more intentional now to be very systematic, because there's no nice way to elegantly link the case. And I think what Reza is alluding to is when you see AST and ALT elevation, you should think liver until proven otherwise. And then the reasons you should start to think until proven otherwise is the patient has symptoms compatible with a myopathy, and the patient has an important discordance. We see that she has 3+ blood and no red blood cells, which means that something is reacting with her globin marker in her urine, but it's not red blood cells. So what could it be? It could only be two other things. It could be free hemoglobin as a result of intravascular hemolysis, and that's when you look at the hemoglobin, it's normal, or myoglobin. So this makes a reasonable case that this is one of those instances where you might be dealing with both a hepatic and myopathic process, or a pure myopathic process alone, in which case the trend of the liver enzymes would probably be like static and not evolving. And so you'd probably say, oh, and that's probably just a CK. So a CK is definitely going to be helpful here. But that's not the only abnormal thing on the UA. This is a 53-year-old non-diabetic patient with 2+ proteinuria. And when you look and you see that she's losing protein in her urine, and then you look at her albumin, you see like, hey, is she gonna meet criteria for nephrotic syndrome? The key thing to make sure you don't make the mistake of is to call this nephritic, because there is no blood in the urine. So even though there's 3+ blood, you've proven that those blood is not red blood cells. So this, you could easily go down the path of nephritic syndrome, but I would say that the case here with a normal creatinine, hypoalbuminemia, and 2+ protein is for nephrotic syndrome. Now, here's the roadblock that I hit. Most nephrotic syndrome is usually isolated to the kidney itself without any consequences anywhere else. It's primary idiopathic disease. And I think Shema just said it. The one commonly systemic disease with nephrotic syndrome is amyloidosis. And there are a couple of other ones. There's things like lupus and HIV, syphilis. So those are the things that I'm starting to think of. Hey, would lupus explain this? And yeah, you might say, hey, lupus, cerebritis, brainstem disease, nephrotic syndrome, liver involvement, muscle involvement. Yeah, possibly. How could a cancer be at play here? Well, you might say, look, there might be a cancer causing membranous nephropathy, which is classically associated with a normal creatinine and marked hypoalbuminemia, causing a paraneoplastic myopathy and a paraneoplastic brainstem issue. But all these hypotheses are very far-fetched. I think the key is, what's the CK? What's the urine to protein to creatinine ratio that will help us clarify, is it a muscle problem or not? Is it a nephrotic syndrome or not? And then, as Reza was alluding to, what does the imaging of the brainstem look like? And after that, can we try to synthesize those? But I think a key thing whenever you see nephrotic syndrome in a systemic disease is think about amyloidosis and lupus in particular. And also don't forget that a paraneoplastic phenomenon is described for membranous nephropathy. All right, Carolyn, back to you.
All right. So she had a negative hepatitis panel. ESR was 28. CRP was 3.1. Her creatine kinase was 6,735. Do you want me to go into some imaging and other diagnostic testing, or? Yeah, okay. So we did an EMG of her wrist, and it showed bilateral severe median neuropathies at both wrists. She also had a CT chest that showed diffuse ground glass opacities, greatest in the lung bases. She had an echo that was normal. And she had an MRI of the thighs that showed diffuse intramuscular and perimuscular edema of the bilateral thigh musculature. It was during COVID times, but she's COVID negative.
I'll interpret the EMG and pass the rest of it for Reza to interpret. And I will say, this case is unbelievable because we know that now the one part we weren't suspecting, a neuropathy, is actually at play. We know that there is upper motor neuron disease because of the teaching that we got about the Jerk Reflex from Gale. We knew to a reasonable extent that there was going to be muscle involvement with the CK because of Carolyn's UA. And now there's also nerve involvement. So all I will say is this case tells you, use this case, all 32 of us, to remind you that whenever we're localizing something neurologically, we're always making an assumption that one lesion accounts for it all. always making that assumption, because that's, we say, which one? Hickham's dictum, I think, whatever one is the one that says that you only have one diagnosis, and the other one says that you can have as many diagnoses as you want. I forget people's names. So this is proof that you can have a muscle problem, a nerve problem, and an upper motor neuron problem in the same patient. Don't ever forget that. All right, Prof. Rez, Mike, to you.
Man, my mind is spinning because just like you, Robbie, it's really hard for me to pinpoint a specific diagnosis with confidence. And I think it goes back to our one episode, and or. Why can't it be, and as opposed to or? And I think what we need to do here, Robbie, is sort of, because when you're faced with such a difficult case, you want to prioritize the problems that the final diagnosis must explain. So like, for example, when I look at an albumin of 2.6, that doesn't make my list. Like, it doesn't make my list. What's making my list in order of importance is, from the HPI, the objective weakness this patient has. Objective weakness, no question about it. From the physical exam is findings consistent with upper motor neuron disease. And what we learned from Gail is probably involving the brain stem. So our final diagnosis must explain this jaw reflex and must explain the hyperreflexia and the CNS pathology that we're expecting. Also, our final diagnosis, the ASC and ALT I put aside, I dismiss it. That's not what my final diagnosis needs to explain. But it must explain the peripheral neuropathy and the elevation in the CK. You might say, well, can we simplify it? Can a nerve problem lead to CK elevation? It can, but low levels. This is where the actual level of elevation is very helpful. So you can't blame this CK elevation on just nerve pathology. It's not that easy, folks. So we know we're dealing with upper motor neuron. We have an EMG and nerve conduction saying that there's bilateral median nerve neuropathy. And I know the mind goes directly to something like transthyretin amyloid, but you have to be cautious here because this disease with the CK elevation, the brain, it's far more than just amyloid, if that's also involved in the final diagnosis. So we have to explain the peripheral neuropathy, like whatever's happening there. And on top of that, we have to explain the myositis and what's happening in the lungs. Like all of these have to be explained. So just to summarize, lung pathology, muscle pathology, peripheral nerve pathology, brainstem, and spinal cord pathology. So you see, we are all over the place. Now you might extract a couple of these problems to quickly come up with a DDX and see if it can explain the other abnormality. For example, if I said, Robbie, muscle and lung, what would we think about? We would think about something like, not to put you on the spot, but we think about something like,
I don't know.
I don't know what I'm
I
doing.
would think autoimmune, all the autoimmune myopathies are poorly named. They should be autoimmune pulmonary myopathies. Almost all of them have pulmonary manifestations.
Beautiful. That's exactly where my mind went. Then I was like, okay, so if we're dealing with dermatomyositis, how the heck do I explain the median neuropathy? How do I explain the brainstem and the spinal cord? Then I'm like, well, with dermatomyositis, it can be, a perineoplastic phenomenon. Well, can the other stuff also be perineoplastic in nature with this sort of widespread disease? Possibly. So where I am right now, folks, is I'm like, is there an autoimmune disease at play? And I think it wouldn't be one of your common inflammatory myopathies, being polymyositis, dermatomyositis, inclusion body myositis. You have a necrotizing autoimmune myositis. Usually the CK is very high. The CK can be low in that case if you have a lot of muscle atrophy. And that one, we often associate with statin with HMG-CoA reductase antibody, but it can be anti-SRP perineoplastic antibody. So I just don't like the autoimmune inflammatory myopathies exclusively explaining the whole presentation. Though dermatomyositis, we didn't get any evidence of a rash. We don't have to get evidence of a rash. So Robbie, I want to give the mic back to you because I'm having difficulty coming up with a unifying diagnosis. And I went through those acronyms of POEMs like polyneuropathy but we're not really getting much of that flavor either. So what would I do next? I'm not sure where the final diagnosis is, but to better understand one of the problems that I have to explain, I would get an MRI of the brain and spinal cord, and then I may pursue a lumbar puncture, evaluating for one, intrathecal inflammation and some kind of paraneoplastic myelitis, and it would have to be paraneoplastic neuropathy on top of that. Robbie, what do you think?
I'm trying to use all the data that we have today, including Carolyn's facial expressions and responses to guide us. And she's like just the perfect presenter. She's like, nothing. Like not anything that you said is getting a smile or like a response out of her, except this comment. So I don't know. I'm stumped too, and that path hasn't led us anywhere. I'd say this is one of the most intriguing cases I've been involved with for a very long time, because every path leads to a roadblock. But I'd say that right now, I think the real question, the questions that I'm like trying to simplify this, you could say the muscle and the lung stuff are connected. I'm going to collapse those and put them somewhere else. I can't explain the median nerve, and I can't explain the upper motor neuron findings. And how would you proceed? I think it's hard not to say clubbing without overt inflammation equals cancer in general. Muscle involvement plus lung equals things that are robustly associated with cancer, the autoimmune myopathies. Nephrotic syndrome is usually cancer or lupus, and a 53-year-old presenting with lupus, unlikely. So there's so many pathways that lead to malignancy as the concern. And the question is it a solid malignancy with a paraneoplastic phenomenon, which is usually associated with autoimmune myopathies and membranous nephropathy, or is it a liquid tumor like multiple myeloma with amyloid that's causing deposition everywhere? But I'm really worried about cancer in this patient because infection doesn't seem to be robustly present. Primary autoimmune diseases without an underlying paraneoplastic phenomenon usually have a beautiful illness script that clearly this patient is not reading. And I learned from one of the rheumatologists here, whenever you have an autoimmune disease that's not lining up like it should, either because the symptoms are weird or because the serologies, like you have somebody with a high ANA titer, but also like very funky serologies that don't quite make sense, think about cancer triggering. So I'm really worried that we have a malignancy here. All right, Caroline, back to you. Carolyn, sorry.
All right. Yes, this patient was admitted to internal medicine, and a bunch of different specialties were consulted for reasons that you all have mentioned. Her ANA was positive at 1,280 with an atypical speckled pattern. She had negative anti-Smith, anti-double-stranded DNA, anti-smooth muscle, anti-SSB, anti-HMG-CoA reductase, anti-CCP rheumatoid factor, but mildly elevated anti-RNP, and a very positive anti-Jo1 antibody, very positive anti-SSA antibody. She also had muscle biopsy, and that pathology is still pending, and what they call an extended biomarker panel that has some additional antibodies that's still pending. So ultimately, rheumatology said the diagnosis is anti-synthetase syndrome with Sjogren's overlap. To kind of go through we went through a lot of that same thought process that you all did. In terms of the jaw jerk, the neurologist actually said that was reassuring because she has this hyperreflexia everywhere. If it's also in the jaw jerk, you're more assured that it's not in the spinal cord, kind of as you said, because that's above the spinal cord. So he saw that as just sort of like a hyperreflexic patient. It's not necessarily pathologic, and that jaw jerk was reassuring that it's not actually located in the central nervous system an issue. Obviously, the inflammatory myositis could be explained, by the anti-Jo antibody that's seen in myositis and interstitial lung disease, as well as you said. The thinking from the neurology and rheumatology teams about the carpal tunnel syndrome is that, kind of like you said early on in the case, you can get all this edema, and it can actually cause compression of the carpal tunnel and cause these median neuropathies. So that's what they've attributed it to, especially because it improved with treatment with steroids and IVIG. Renal was not too concerned about her UA because it cleared up except for that blood, which they attributed just to the muscle breakdown. they said the proteinuria can actually be caused by the rhabdomyolysis, causing tubular damage. And so you can get protein in the urine, and it cleared up as well with treatment. Yeah, I don't know what else is still a mystery on here, but thanks. Oh, and your comments about this being paraneoplastic, that was mentioned by rheumatology, and apparently that's even more common if you find multiple antibodies like you do in this patient. You really need to be concerned for some sort of underlying malignancy. And so she is kind of being worked up for that right now. So far, thankfully, everything's been negative. She's had CT abdomen, pelvis, already had the CT chest, no multiple myeloma. They worked her up for that as well. So yeah.
Carolyn, this is absolutely amazing. Oh, you were going to say something? So go ahead.
I just saw someone asking how she was treated. Yeah, so she got steroids and IVIG in the hospital. She stayed with us for about 7 days and then was doing significantly better, like clinically was much better feeling. Even the weakness was improved already. And her CK was down to like 1400 by the time she left. Oh, and the AST, ALT were also attributed to muscle breakdown. Although, like you said, the fact that the ALT was high made us unsure, but that resolved too with treatment. So yeah, so she's going to continue to have follow-up, but she's doing well. She's also started on CellCept, which is mycophenolate.
Wow. Carolyn, this is just absolutely unbelievable. And I think that we can learn so much about each individual in the script, but I think that what you're showing us is that in real life, sometimes the simplest way to solve a problem is to realize what pieces you think you can explain away. And it's amazing how much easier this problem becomes when a neurologist comes and says, hey, what are you worried about? There's no problem here. This is just a patient who tends to have elevated reflex without overt pathology. And that makes the rest of the problem so much easier to solve. And when a nephrologist comes and says, hey, don't worry about the proteinuria, it's just because of the rhabdo. Like sometimes the exercise is to actually simplify the problem as much as you can. And yeah, I think, the combination of muscle plus lung is rare. There's not many things that do muscle and lung together at the same time. They're very distant organs. And I think that is the simplest way to solve this, to say this is a middle-aged woman with a positive ANA and muscle and lung problem, which elegantly goes to support the hypothesis that you have. I really, really enjoyed this case. I'll pass the mic to Prof. Rez for his reflection.
Yeah, me too, Carolyn. Thank you so much for bringing this case. And it shows you, regardless of how comfortable you are with various illness scripts or approaches, this is where you learn medicine is quite humbling in trying to distinguish signal from noise. And like Robbie said, if you are able to correctly identify the signal, then you'll be solving the right problem. But if you sort of take something, a signal that's not here, really the neurologic syndrome, then all of a sudden you're climbing the wrong hill. So how can we get better going forward? I'm not sure like there's a lesion or like room for improvement in signal versus noise. It's just being open to the fact that like trying to prioritize what, pathology must be. And here we were like, look, lung and clubbing, muscle injury, these have to be explained. And maybe giving those more of a priority, so framing it more of a lung and muscle problem as opposed to lung, muscle, and neurology problem, but also being okay with it. So what? We didn't know. Now we know, that if you're having reflexes everywhere that's hyper and this is also hyper, it could just be a normal variation of that. Though I think what, made me really focus in on the nerves was one, that median nerve pathology, I know it was due to the edema, and then the shooting sensation that the patient had, like that just really made me, and the numbness in the feet, sort of hang on to the nerves. So anyways, very good case. What an enigma. And thank you, Carolyn, for joining us New Year's Eve. And once again, Happy New Year's to everyone. We'll give the mic to the incredible Rafa.
So thank you, Carolyn, like incredible case. Like we were on the edge of the seat until the very end. So we had this patient with weakness, and first we thought about if this was be symmetric or preeminent at rest. And then there's also this thing that we usually ask ourselves when it comes to weakness, if this is true weakness, like neurological in nature, or just asthenia. And we saw that this patient on the history had like tingling and shooting sensation. So we were tending more towards a neurological cause. And then Reza reminded us to think when it comes to neurological etiologies to think about time course into 4 buckets: hyperacute, like migraine, stroke, Acute, like inflammatory causes, typical bacterial infections, demyelinating disease. Subacute, like neoplasia, paraneoplastic syndrome, and atypical organisms. And when it comes to chronic neurodegenerative etiologies like Alzheimer's disease. And we have to remember that vaccines can actually manifest as acute or subacute causes. And then when it comes to localization, which is another aspect that we think about when dealing with neurological cases, we have to think about upper and lower motor neurons. If there's damage to the upper motor neurons, we have to think about weakness, increased reflex and tone, Babinski, spastic paresis. Those neurons are found on the brainstem, on the cortex. Lower motor neurons are on the anterior part of the spinal cord. And then we have to think about weakness, fasciculation, decreased reflex, tone, flaccid paralysis. And then when it comes to the edema, Ravi reminds us that it's actually kind of rare to associate that with the neuroaxis, or we just had to attribute that to another common etiologies like venous stasis, nephrogenic, hepatic, cardiogenic, or lymphatic etiologies. And then we saw that this patient had clubbing on the physical exam. And I have to remember that this is due to chronic hypoxia leading to flattening of the nail folds. This is associated with lung disease like malignancy, infectious, the heart like endocarditis, GI like IBD, cirrhosis, endocrine like Graves, and even malabsorption. And another pearl that I really loved from Rabi, that on the urinalysis we saw blood, but no RBCs. And we have to think about true causes: free hemoglobin and setting up intravascular hemolysis. Less likely because there was no increased LDH or decreased hepatoglobin, or even myoglobinuria. And then finally, which was the diagnosis, we saw that this patient actually had Jogging Syndrome. And this is an autoimmune destruction of exocrine glands, and it can be primarily associated with other autoimmune diseases like SLE, rheumatoid arthritis. And this is can be diagnosed with a very positive anti-oral or anti-LI antibodies. And finally, this is also associated also with antisynthetase syndrome, which is actually when you have autoantibodies against tRNA synthetase, and this manifests as ILD, myositis, arthritis, and even Raynaud's phenomenon. So thank you, everyone. Such a very nice case, and I hope to see everyone on Monday with our pulmonary critical care specialist, Dr. Kelly from Mayo Clinic. We don't have global VMR tomorrow.
Thank you, Rafa.
I didn't ask Rafa.
I was ready this time.
He anticipated the question, Robbie.
He did. He really did. Happy New Year, all. And thank you again, Carolyn, for such a wonderful case. A great way to cap off VMR. I couldn't have gone any better. Thank you.